the question is, maybe I'll go back to Amit and ask him, like, checkpoint inhibitors, 20%. We just heard about a drug called lenvatinib, close to 41% response rate. Like, is there any preference which patient gets what, or how do you explain all of that?
Yeah, I think the big thing that's exciting about the immunotherapy and the Checkmate 040 data, I mean, the response rates we see, I mean, you see response rates in the resource trial, you see it in the Reflect trial, you see it in the Checkmate 040 trial. So you see this with TKI therapies, and you see it with immunotherapy, but the difference is the durability of that response. And so with the TKI therapies, the response while you have it tends to be short-lived. And the fascinating thing and the most exciting thing, at least in my mind, with Checkmate 040, is that these responses are durable. So when you take a look at this is several months, I mean, even greater than 12 months in many of the patients. So when you have that durability of response, there's a higher likelihood that it's going to translate into meaningful survival differences. And so I think that's the biggest thing that's exciting here.
That you bring a very important point. Actually, for all of us who are now familiarizing ourselves with different ways of looking at data, you remember we used to see numbers, response rates. Out of nothing, we're seeing waterfall plots, which show how much response, and you see how much non-response. And out of nothing, we're seeing swimmer's plot, which is how long the response will stay. And this is really what we're referring to in regard to the checkpoint inhibitors. And my question is to Mark. So you have a patient on nivolumab, let's assume, getting a response, they stay on the therapy for X long period of time. Would you stop it at some point, or what does the data show?
I think that's the question in IO therapy, and pretty much every cancer that we treat the IO therapy is how long is too long. And in general, I think what tends to happen is we continue it as long as they're responding, because it's hard to sort of rationalize saying, hey, let's stop this therapy that seems to be working, because you don't want to kick yourself at the end if it ends up growing after that.
So
we don't know the answer still, I think.
Yeah.
If they're tolerating it, I stick to it. If not, then sort of if they're having some side effects that make me concerned, whether it be immune mediated or just sort of a side effect like fatigue or joint aches or something like that that's really bothersome from a quality of life perspective, I will stop it, pointing to other data and other cancers saying that maybe we would be able to actually still keep a durable response.
I hear you. And you're right, actually, this is being looked at in other diseases. Manish, along that line, what's your hands-on experience in regard to the tolerance and adverse events from the checkpoint inhibitors?
I mean, really, we have experience in many diseases, right? And that's, so from the medical oncology perspective, my experience with nivolumab and other checkpoint inhibitors was in other diseases before it was in HCC, because HCC came later in the game.
Yeah.
And my experience has been that these are generally very well-tolerated therapies. The number I tell patients, which I think is accurate, is that about 90% of patients will tolerate it with minimal or no side effects, and about 10% will have more significant side effects, and those tend to be sometimes things like fatigue or nausea or diarrhea. We, of course, get excited about immune-related adverse events, and those are very important to recognize, and I think that's the big thing. Now with checkpoint inhibitors being in such common use, I think oncologists have become much more comfortable with how to manage those, stopping the drug, giving high doses of steroids, et cetera. But my experience in HCC has been that the tolerability is not really fundamentally any different than it is in any other disease. We always get concerned that, okay, these are patients with liver disease, or could they have a higher risk of immune-related hepatitis, because the liver is sort of, maybe inflamed because of hepatitis or whatever else. But we really haven't seen, I don't think, higher toxicity rates with the checkpoint inhibitors in HCC compared to any other disease, which has been exciting. So then you're combining what Amit is saying about durability of response with now a really well-tolerated therapy. So from the patient perspective, that's very attractive.
Yeah, no, I totally agree. If anything, thankfully, they're not necessarily common, but they can be serious. Actually, one of the teaching points I hear every now and then is like everything is side effects with the checkpoint inhibitors until proven otherwise, because really you can't tell how the immune response might be. And this is novel to us in regard to the practice in oncology. Along that line, we hear about other checkpoint inhibitors, and there's quite a bit of data data coming out, and we talk about it in regard to pembrolizumab. Can you tell us a little bit more, Ruth?
Yeah, so pembrolizumab has been tested in a phase 2 study, 224, the keynote 224, and in comparison with placebo has shown a response. It's the efficacy, the response rate is very similar to nivolumab. I think it probably just tells us that because the mechanism of action is the same. And also the response can be durable. And because of that data now, pembrolizumab has been tested in the second-line setting in a phase 3 study that has complete enrollment in 2017 now, and now we're waiting for the survival data. And so, and then there's additional immune checkpoint inhibitors such as tremelimumab and durvalumab, and also atezolizumab. They're all in the clinical trial ground to be tested for liver cancer.
Sure. So Mark, okay, great. We have a lot of checkpoint inhibitors and definitely a lot of promise there. What are we going to do with them ultimately? Are we going to mix them together, mix them with something else? Like any argument one way or the other for this or that?
Well, so far, when you, my opinion is if you mix a PDL1 drug with a CTLA4 drug, you get more toxicity. In liver cancer, you don't get more benefit. Maybe in melanoma, but not in liver cancer.
Ironically, I might disagree a little bit on that one, but interestingly, because we have hands-on experience in regard to durvalumab plus tremelimumab, and if anything, we are seeing incredible responses. And if anything, the toxicity did not necessarily differ from what we know about the single agents. So I would like to kind of maybe refresh my mind from other perspective there, because interestingly, we know that there is a huge ongoing trial in regard to HCC, which is looking at the durvalumab plus tremi versus another dosing of durvalumab plus tremi versus durva versus sorafenib, 1,200 patients, the Himalaya study. It's going to be very important in regard to ultimately what's the role of anti-PD-1 plus anti-CTLA4, because remember, in regard to the biology, how these things are connected, because all what it is about connectivity between the T cell and the tumor, and we are trying to break every bridge we can to prevent that T cell from attacking the tumor. And definitely having a break of 2 bridges will make it much easier than it is if it was 1 per se. So quite a bit going on in that regard, but at least now we know that we have the potential of using a checkpoint inhibitors in regard to HCC, pending further data that will wait until we see what the nivolumab versus sorafenib study will show.